Thank you very much. I welcome everyone here tonight. I'm Dr. Adigun, as I've already been introduced. And today I'm talking about neuropathic pain, current trend in the management of diabetic neuropathy. And I'm going to follow this outline. Introduction, definition, pathophysiology, clinical features of diabetic neuropathic pain, mechanism of pain generation, assessment of pain, pharmacological treatments, non-pharmacological treatments, and I'm going to conclude. As we all know, diabetic mellitus is a group of medical disorder that is common in our environment. It's a metabolic disorder that affects the metabolism of fats, carbohydrates, and protein due to absolute or relative lack of insulin, thereby leading to hyperglycemia. Diabetic neuropathy is one of the most prevalent long-term complications of diabetic mellitus that are resulting in greater morbidity, mortality, deterioration of patients' quality of life, and is one of the causes of non-traumatic amputation in our environment, causing leg ulcers and chronic leg ulcer amputation in our environment. Epidemiological studies suggest that 50% of patients with diabetic mellitus will develop diabetic neuropathy 15 years after the onset of the disease. So it's been known that long duration of diabetic mellitus will prone the patient to diabetic neuropathy. Diabetic neuropathy are a heterogeneous group of conditions affecting the peripheral nervous system. The true prevalence of diabetic neuropathy is unknown. However, we know that the prevalence is increasing worldwide. It affects 2.4 to 7% of population. In our own environment in Nigeria, we have a high number of patients with diabetic mellitus. And diabetic neuropathy is commoner in type 1 as compared to type 2. In a systematic review of done in Nigeria by Aziz et al. In University College Hospital, noticed that the prevalence of diabetic neuropathy was between 31.2 to 97.5%. This wide range was mainly due to the criteria used by different authors in Nigeria and the definition of neuropathy used. We can see that there is a different prevalences of diabetic mellitus across the geopolitical zone in Nigeria. So this is done by Aziz et al., as I've said before. You can see that a higher prevalence was found in the South-South, 9.8%, Northeast, 5.9%, Northwest, 3%. And this is the paper of Aziz et al. Showing the systematic review of diabetic neuropathy in Nigerian patients. Definition of diabetic neuropathy is internationally agreed to be the presence of symptoms and signs of peripheral nerve dysfunction in people with diabetes after exclusion of other causes of neuropathy. Diabetic neuropathy is a diagnosis of exclusion, having excluded other causes of neuropathy like alcoholism, inflammatory, vitamin B deficiency, toxins, and other metabolic disorders. Diabetic neuropathy simply means affectation of the nerves by diabetes mellitus. It can affect the sensory, the motor, or the autonomic nervous system. The small fibers and the large fibers are involved in the diabetic neuropathy. The small fibers causes superficial pain, electrical shooting, burning sensation, allodynia, autonomic dysfunction, thermal impairments, but has a normal reflexes. Patient will have normal reflexes. While the large fiber neuropathy will cause deep pain, which is mediated by alpha delta type, and mainly patient will have muscle weakness, wasting, numbness, pin and needle, ataxia, reduction in sensitivity to light touch, vibration, and patient can have risk of falling and fracture. What are the risk factors for patients to develop diabetic neuropathy? We have the modified risk factor, poor glycemic control, alcoholism, hypertension, smoking, hyperlipidemia, obesity. While the non-modifiable risk factor include old age, gender, family history, long duration of diabetes, presence of other complications like nephropathy and neuropathy. There are two, or we can say there are two types of diabetic neuropathy, or classification of diabetic neuropathy into two types. We have the diffuse neuropathy or the focal neuropathy. The diffuse one is commoner and is commoner than the focal. The diffuse one includes the distal symmetric sensorineural neuropathy, which affect the large and the small fibers, and is the commonest form. You have the autonomic neuropathy, symmetric proximal lower motor neuropathy. Then the focal one, which can be mononeuropathy, as is only one nerve can be affected, multiple mononeuropathy, entrapment neuropathy. We can have cranial neuropathy. The third, fourth, sixth, and seventh cranial nerves can be affected. And we also have the truncal neuropathy, which we can mimic episodes in the trunk. What is the cause of diabetic neuropathy? The pathophysiology of diabetic neuropathy mainly is due to the hyperglycemia in patients, which affects the vessels, causing microangiopathy and the macroangiopathy. So chronic diabetes or chronic hyperglycemia causes oxidative and osmotic stresses, endothelial dysfunction, impaired vascular regulations. So there are the cause of diabetic neuropathies is actually the cause is really not really known. There are a lot of postulation. Number one is increased aldose reductase activities. Hyperglycemia leads to increased activity of the enzyme aldose reductase, which leads to accumulation of sorbitol and fructose and decrease the free nerve inositol. This impair the blood supply to the nerves. Another postulation is protein glycation. Hyperglycemia leads to incorporation of glucose into the protein non-enzymatically by unregulated glycation reaction. This is also responsible for nerve damage that is seen in diabetic neuropathy. Another postulation is the autooxidation of glucose. The hyperglycemia leads to a lot of autooxidation with a lot of free radicals, and free radicals have been found to inhibit citric oxide, which causes endothelial damage, leading to ischemia of nerves. Then another postulation is inappropriate activation of protein kinase C, reducing serum levels of nerve growth factors. So hyperglycemia has been noticed to be the cause of diabetic neuropathy. A lot of glucose is deposited in the basement membrane, causing ischemia, nerve inflammation, neuronal death, and hypoxia of the nerves. What are the clinical features of diabetic neuropathy? Diabetic neuropathic symptoms varies from asymptomatic to symptomatic neuropathic pain. Symptoms are predominantly sensory and can be positive, which includes the tingling, the pin and needles, burning sensation, stabbing pain or shooting pain, throbbing sensation associated with hyperalgesia or allodynia or cramps. So these are the pains which are the neuropathic pains that we see. It can also be negative, in which there will be sensory loss, numbness in the hands and feet. The patient will feel walking on curtains. Diabetic neuropathy are mainly in the distal or proximal weakness. Ankles reflexes are absent. Symptoms often start from the toes until it involves the lower or the upper limbs in glove and stocking distribution pattern. Then we can also have distal symmetric polyneuropathies. Neuropathic pains contribute poorly to quality of life by causing sleep disturbances, anxiety, depression, affecting work, self-work. There might be impotence. It affects recreation and social activities. How do we assess patients for neuropathic pain? History is very important. The type of pain, patient presenting with pain, discomfort, numbness in the leg. Patient will also take history, know the onset, provoking, quality, radiation, severity, time, and the treatment, the drug, that is the drug the patient has been on before coming to us. Then we can also assess the pain by doing it can be numerical rating scale by scoring the pain score. History of comorbidities like diabetes, hypertension, and any other organ damage like the nephropathy or the retinopathy is also taken. Physical examination of the skin, especially the limbs. Check the color, the vascular perfusion. We do neurological examination, doing the lights, gross light touch, pinprick sensation using cotton wool pins or monofilament. Monofilament test is used to evaluate the touch sensitivity and tactile circumference discrimination. Vibration test by tuning fork is also being done by placing the tuning fork on bony prominences. Deep tendon reflexes are commonly hypoactive or absent. Absent or decreased ankle reflexes occur early stage in the disease, while widespread loss of reflexes and motor weaknesses are late findings. Other instruments like neuropathic symptom score, especially we can use, the common one is the Michigan neuropathic screening instrument, and can be used to assess the how severe neuropathic pain is. Then we can also do neuroconduction studies or muscle myogram. We can also do skin biopsy. What's the mechanism of pain in neuropathic pain? The mechanism of pain in painful diabetic neuropathy is mainly by sensitization. The damaged peripheral nerves lead to hyperexcitation of the primary efferent nociceptors. That's peripheral sensitization. This can also lead to excitability in central neuron, the central sensitization. Sensitization refers to a lower activation threshold, increased response to a given stimulus, and abnormal spontaneous activities. This generates sympathetic mediated pain vasoconstriction, leading into inappropriate blood flow regulation. Accumulation of sodium channel at the site of injury along the length of the nerve fiber, leading to ectopic electric discharge, causing hyperexcitability, leading to increased burst of electrical activities. So what we are just saying is that we've already talked about the pathophysiology that leads to the damaged peripheral nerves. All the things we talk about, the hyperoxides, the free radicals, and the hyperglycemia cause damaging the cells of the neurons. When they are damaged, then the nerves become hyperexcited and they start discharging. That's peripheral sensitization. And this can also lead to central sensitization. So how do we treat patients with diabetic neuropathy? Diagnosis is important. So before we can treat, we must have diagnosis. And we have already said how to take diagnosis: history, physical examination, and we also confirm by laboratory investigation. And what's the treatment? So if we follow this outline, lifestyle modification is, we have lifestyle modification. So we have lifestyle modification. We've already talked about the risk factor that leads to diabetic neuropathy. Then we have the asymptomatic one and the symptomatic one. So we go into it. So the first one we are going to talk about is the lifestyle modification, healthy eating plan. Intensive patient is diabetic, and chronic hyperglycemia has been known to cause diabetic neuropathy over time. So if the blood sugar is not well controlled, then the patient will develop diabetic neuropathy over time. So intensive glycemic control is very important in the range of blood sugar in the range of 80 to 120 milligram per kg should be achieved. 80 to 120 milligram should be achieved. Sorry about that. Then we have the blood pressure should be also be controlled. Physical activity, exercise, physiotherapy, the role of weight management cannot be overemphasized. Then other lifestyle modification, like patients should stop smoking and should avoid alcohol. So lifestyle modification is very important: eating healthy, controlling blood sugar, blood pressure. Then number 2 is pathogenesis-derived pharmacotherapy. There are drugs that have been developed along the pathway of the pathology of the diabetic neuropathy. For instance, alpha-lipoic acid is an antioxidant with radical scavenge and has been proven to improve symptoms. Another one is gamma-linolenic acid, constituent of neural membrane and preserve nerve blood flow. Aldose reductase inhibitor, it inhibits polyol pathway, which prevents the conversion of glucose to sorbitol. The vascular endothelial growth factor, its role in diabetic neuropathy has been documented in rat and rabbit models of diabetes. It restores conduction velocity and nerve blood flow. So these are ways, these are medications that are being used. So these are medications that are being used along the pathogenesis of the diabetic neuropathy and has been found to improve treatment. But mainly the patient will present with pain, and analgesic treatment is very important because patients will have pain and associated depression with it and affecting the patient. Therefore, this drug analgesic treatment is very important. An example is tricyclic antidepressant, amitriptyline or nortriptyline can be used. Serotonin, norepinephrine reuptake inhibitor can also be used. Anticonvulsant, pregabalin, it has anti-epileptic, analgesic, and anxiolytic can be used. Gabapentin, alpha-2, delta-2, voltage-gated calcium modulator can also be used. Opioid analgesics, morphine, oxycodone, tramadol has been tried and has been found to be useful. Non-steroidal anti-inflammatory agents, ibuprofen, diclofenac can be used in acute phase. NMDA receptor antagonists like ketamine can also be used. Other non-pharmacological agents can be used, like acupuncture has been tried, which has a benefit over a 6-month period. Trans-electrical nerve stimulator can also be used. Surgical sympathectomy has been tried. Spinal cord stimulation, central neuralgia blockade, static magnetic field therapy, low intensity laser therapy, monochromatic infrared light, and psychotherapy has all been used in the management of patients with in diabetic neuropathic pain. Also, local creams can also be applied to patients to the sites of pain. Example is topical capsaicin, 8% capsaicin patch has high sensitivity for some subsets of sensory neurons, or 5% lidocaine patch has also been used, maximum of 4 with relief of diabetic neuropathic pain. Physiotherapy have been shown to improve muscle function, reduce neuropathic pain, control sugar level, improve quality of life, and can explain some in neuropathic mononeuropathies. Example, the carpal tunnel syndrome can be explained with the help of the physiotherapy. Splints can also be applied. What are the recommendations? How do we apply all these things that we have said or that I have said? Number one, first line treatment or management is to consider anticonvulsants, pregabalin and gabapentin, tricyclic antidepressants, serotonin noradrenaline uptake inhibitor are strongly recommended as first line. So when patient comes with diabetic neuropathy, the first line of treatment is pregabalin, anticonvulsants, or tricyclic antidepressants. Pregabalin and gabapentin has been shown to improve the quality of sleep both directly and through relief of pain. Second line management or treatment, we can add lidocaine patches, capsaicin patches, and tramadol add-on. We can also add carbamazepine or sodium valproate, or they are weekly, although they are weekly recommended. The third line treatment includes strong opioids like morphine and botulinum toxin A are weekly recommended as third line treatment. So I'm going to conclude by saying that diabetic mellitus is a medical condition that is common in our environment, and patients with diabetic mellitus, after a long period of time, can develop diabetic neuropathy. And diabetic neuropathy can be asymptomatic or can be symptomatic. And the symptomatic one is the diabetic neuropathic pain. And there are multimodal treatments has been considered in patients with diabetic neuropathy. Early recognition and detection of diabetic neuropathy is important. Modification lifestyle, especially the risk factor, then adequate glycemic control, then pathogenesis-derived treatment and pain management using the pharmacotherapy and the non-pharmacological method of pain management will help in success treatment of these patients. Thank you very much. And that's the end of my presentation. And these are my references. Thank you very much.
Thank you, Dr. Adigun, for this succinct presentation, which has captured the essence of the topic. And it is now time for members who might have one comment or question or the other. Maybe I can just start off by asking that I'm wondering why we have this very wide range of prevalence at UCH. Can you speak further about that? I know you did say one or two things, from 30 to 90-something% or so.
Yes, it's a systematic review that collected all the papers on diabetic neuropathy in Nigeria, ranging from south, northeast, northwest, southeast, north central, and northwest. So that's why the prevalence is wide, and it's mainly due to the different criteria used by different authors and the definition of neuropathies that has been used in their studies. There are different range in different populations. Even in Africa, in UK, they are different. But I only come down to the Africa prevalence, especially Nigeria, which is wide, 31.2 to 97.5 by Aziz Eto from UCH. Thank you.
Thank you, Doc. The next one I want to ask before I call people is that you mentioned monofilaments and biopsy. I mean, how common is this? Commonly is this used in your center or in Nigeria? Do you have an idea?
The monofilament is a research instrument, but it's not difficult. It's being used by the physician. We have thin filaments, which is used to test for diabetic neuropathy. So it's being used, is for research purposes. It's being used. Thank you.
Okay.
The biopsy may not be used very well, but because it's more of the diagnosis is more of clinical than laboratory. So maybe it's just for research purposes. Thank you.
Thank you very much. I actually asked that last question because I'm a basic scientist, and I have at least some monofilament, the form-free filament that we use for our experiments in the laboratory. And I know it is also applicable in the clinical settings, but I don't treat patients, but I induce diabetic neuropathy, I induce sensory neuropathy in animals. And I was privileged to be in a lab in the US in Massachusetts General Hospital where biopsy are routinely done for people with neuropathy. And I think it's something that we can adopt in the clinical setting in Nigeria.
Thank you. It's something that they use for research purposes in our center. Thank you very much.
All right, thank you very much, madam. There's a question here. It says pregabalin and gabapentin. You can also scroll through the charts. He said, I have observed as a neuropathic and asthmatic patient that they both aggravate my asthma symptoms. I reacted differently to carbamazepine. Am I the one reacting, or they all have this? That's from Professor Adedokun Shitu. Do you have anything to say about this, madam?
Pregabalin and gabapentin, I've observed as in a neuropathic and the asthmatic patient that they both aggravate my asthma. Well, maybe it's you, sir. I also know somebody that uses pregabalin a lot and does not cause any respiratory problem. I know it causes it causes dryness of the throat. It causes sedation. So it may be you, sir. I think so, sir. I think so.
Okay, that's
I don't think asthma is part of the side effect of pregabalin. I know of sedation, dryness of mouth. I know of those ones. But asthma is not there. Thank you.
Thank you. She is actually a professor.
Okay.
Thank you. He said, and Dr. Lajide Sunday said, after how many years of diabetic mellitus in a patient with neuropathy likely setting?
I said 15 years, but I saw somewhere 25 years. So I think it's also a range. I saw 15 years in the literature. I also saw 25 years. So the 15 years seems to be a recent paper, while the 25 years are old papers. So I think many people are having diabetic neuropathy even before 15 years now. But it's a recent paper that is even there was a paper that I even read. They collected 5 years of diagnosis of diabetic mellitus, and they have some people that are already having diabetic neuropathy amongst them. So it shows that long duration of diabetic mellitus is a risk factor for diabetic neuropathy. So I think between 15 and 25 years, patient will start developing diabetic neuropathy. It may even be shorter in our environment. Thank you. Especially when patients have poor control of their diabetes.
So at least it's not likely to start the very first year that the diabetes mellitus started, but might it be a function of the level of hyperglycemia actually?
Yes, if the hyperglycemia is not well controlled, then the patient will develop the diabetes faster than in patients who is well controlled.
Thank you. There's a question from, well, the name is not there. It said, what is the most current effective treatment of diabetic neuropathy in you? Okay, let's say
UI. In
UI, because this one say UITH, but this is UCH now. You are from UCH.
Yes. The current treatment in UCH is pregabalin, gabapentin, carbamazepine is not favored, but pregabalin, gabapentin, they use it a lot for diabetic neuropathy.
I can see that these are also common medication for neuropathy, whether they are not, whether it's sensory or is diabetic neuropathy.
Yes. Diabetic neuropathy, first line is pregabalin, gabapentin, and if patient has depression, tricyclic antidepressants can also be added, amitriptyline.
All right, thank you, madam. Another question is, what is the way for, okay, he said, if there is a diabetic mellitus is hereditary, what is the way forward to save a lineage from that?
Is screening, checking our blood sugar regularly, early detection, prompt treatments. There is nothing, if it is hereditary, there is nothing we can do. It's passed down. Then lifestyle modification is also important. Even if you are if you have lineage that are diabetic, but if our own lifestyle is not the obese type, is not the sedentary lifestyle, if we are active, then it may, the onset may be longer to develop the diabetes. So lifestyle modification is very important to reduce the diabetes, to reduce the diabetes mellitus.
All right.
The onset, yes, thank you.
The other one is how often is spinal cord stimulation used in Nigeria? And can you tell us the success rates? Do you use that for?
Sorry, I don't have experience with spinal cord stimulation. I'm sorry.
Thank you. The professor that asked about the pregabalin and also is asking what would she do, or what should she do? Do you have any advice?
That has asthma?
Yes. And you said that it might be related to her, maybe a peculiar case to her.
And she said she has tried carbamazepine and is not causing asthmatic attack for her. Then she has to use something that is not causing the asthmatic attack. I think that would be best for her.
All right. Thank you very much. Dr. Montayo Salami said, when we combine some of the medications highlighted, how affordable are they in the light of the economic effect of diabetic mellitus itself? Are they cheap to get?
Well, I think well, things are getting more expensive these days. I know somebody that is using pregabalin for diabetic neuropathy. I think initially it was like 700 naira, but by the time the person started using it, then the price has gone up. It's now selling up to like 253. Even some brands are up to 5,000. So it's not that cheap. So, but if is relieving the pain, I think the person will have to we use it. Thank you.
Thank you. Dr. Lateju commented and commended you. Said, thank you, Dr. Adigun, for the brilliant presentation. And is making a plea. If there is any endocrinologist in attendance that can share experience from an endocrinologist's point of view, I think when we are done with reading this, if anybody have any contribution, they can raise up their hand and we'll call them. Another question said, the second and third line of treatment, why do you recommend weekly? That's weekly.
Okay, because the first line is, everything has to do with meta-analysis and also systematic review. So when it was done, it must be statistically significant. So that's why it was weekly. That means it will work for some, it may not work for some. So that is why they say it's weekly. So it's not that perfect. That's what it means. So when it is subjected to statistical analysis, it is weak. That is not that perfect. It's not statistically significant that like for instance, the local cream, if you use the local cream, it's not 100% that patient will have relief pain, but some will definitely have relief pain. So that's why it is a weak line. Thank you very much.
Thank you, Dr. Adigun. At this point, I want to let us know that this webinar is sponsored by ESFA Lab and a pharmaceutical industry with headquarters in Europe and branches in Nigeria. And this is the Society for the Study of Pain Nigeria webinar. I want to call on BOA, I don't know the full name. You can unmute yourself and talk now, ask your question or make your comment. BOA, you can unmute yourself and ask your question or comment. Or if you are finding it difficult, Dr. Olateju, you want to say one thing or the other?
Hello?
Yes. Okay,
Hello?
BOA, you can go ahead. Yes, we are listening.
Yes. I appreciate the presenter for the well-delivered lecture. Yes, the question is, can diabetic neuropathy be reversed with treatment, or is it a lifelong condition? 2, what are the consequences of untreated diabetic neuropathy? Thank you very much.
Thank you very much. Diabetic neuropathy can be reversed. It can be reversed if we talk about hyperglycemia being the cause of the diabetic neuropathy. So if the blood sugar is well controlled, the nerves that are dead can be reversed, and patient is using some medication like the alpha lipoic acid that helps to scavenge the free radicals, increase blood supply to the nerves. By the time patient is using all these things, it's been said that within 2 years, it can reverse. So it can take that long for the diabetic neuropathy to be reversed, up to 2 years. After 2 years, it can be reversed. But the patient must have well-controlled blood sugar. Thank you very much.
Okay, so it's not a condemnation to death or life in diabetic neuropathy. There is this question on the chat box. The presenter should please talk about other treatment, maybe alternative treatment like exercise, dieting, and alternative medicine.
Well, I didn't read about alternative medicine, but I've already talked about lifestyle modification, which includes exercise, controlling obesity, stop smoking, stop taking alcohol, exercise, physiotherapy. That can help to control the neuropathy. So lifestyle modification with drug, then other non-pharmacological agents are also present. But I didn't read about anything about alternative medicine. I didn't read that. Thank you.
All right. Thank you for the answer. Do we have any other questions? While I try to reduce the noise. If you have more questions, you can raise up your hand. But we all know that she has spoken about things like exercise and controlling glycemic control, and which is going to really be of help. So I have maybe a last question if we don't have anybody asking. Is you spoke about painful and non-painful diabetic neuropathy. Can they be interchangeable? Can a painful neuropathy become non-painful, and can non-painful neuropathy become painful?
Yes, the non-painful can become painful. If you look at the pathway, the damage nerves can become like a peripheral sensitization and the central sensitization. So initially, it may not, if the nerves are not firing, then the patient will not have any symptoms. But if something is firing, then it can start to have, patient can start to have pain. And then if the nerves is firing, then if you use drug, you can calm it, and it can become non-painful. I think it can go the other way. Everything depends on the damaged nerves. And the drug that is being used to repair those nerves, if it's working very well, then it can repair it and the nerves can be all right. So I think it can go the other way.
All right, thank you very much. Mama Sonyawo is raising up her hand. Please unmute yourself, ma, and speak.
Yes, thank you very much. Good evening, everybody. I just want to appreciate you all for this webinar. It's quite some time since I joined, but I can see the beauty of a multidisciplinary society, because the topic, can you still hear me?
Yes.
Oh, okay. Because the topic shows that we're truly a multidisciplinary society. And from the discussions and the questions and also the attendance, I can see that SSPN is doing the right thing for the country. And I want to congratulate Professor Oyele for his leadership in moving things forward, and Dr. Adigun for this beautiful lecture. Thank you very much.
Thank you, ma. Thank you, ma. So I would really appreciate you for joining again. For those of us who probably don't know, Mama was a founding member of the Society for the Study of Pain of Nigeria, and is highly distinguished. And a trainer of so many people, produce many professors. So thank you once again, ma. And that is why you can see on this flyer that is being displayed, we have an annual lecture dedicated to her. So, and the third one will be delivered during our annual conference and general meeting. And that conference is coming up at the University of Benin from the 24th to the 27th of July, 2024. Please try to be in attendance. I have scrolled through to show us the registration fee and how to go about abstract. So if you are interested in hearing from different speakers, people with different interests, but having pain as a focus, the Benin is where to be in the last week of July. And without further ado, I don't know if any of the executive members have one thing or the other to say, but we want to appreciate Dr. Adigun. Dr.
Thank you,
are you
sir.
there? Welcome. All right. So I don't think. Okay, Dr. Lateju, I believe you are speaking. We can't hear you.
I'm not speaking.
Okay. So please help us to appreciate Dr. Adigun again.
Okay.
President, sir.
Okay, Professor. Okay.
Yes,
Okay.
sir.
The LOC chairman.
Okay, yes, sir.
Yes, we are listening.
Yes, sir. Yeah, good evening, sir. Good evening, everybody. Good evening, Professor Yawuma. Good evening, President. I just want to add to the comment you have made about the coming conference, and to thank you for also reminding our members to be ready to participate in the conference at the University of Benin in July, and also to say that people should begin to submit the abstract. They should begin to also register. The date that we set as deadline for submission of abstract before has just been corrected today, so it will be posted on the SSPN platform. So there is still room for submission of abstracts. It has been extended, so those who have abstracts should please do well to submit, so that we can have you present your abstract at the conference in Benin. Thank you so much, sir. Thank you, everybody.
Thank you, Prof. Okay. So, Dr. Olateja, are you speaking?
No, sir.
Okay, Professor Ade, you want to say something before we close?
Well, I want to appreciate Dr. Adigun for this highly educative seminar. I have gained a lot of knowledge about diabetic neuropathy, painful one and non-painful one. I never knew that it could be non-painful and painful. Thank you very much, Dr. Adigun. God bless you.
Dr. Adigun is muted. Thank you, Dr. Adigun, and thank you, Professor Akinpelu. Professor Akinpelu is my immediate past president of the society. So we want to appreciate every one of us. It has been a wonderful evening and an educative one. Thank you once again, Dr. Adigun. Just as I'm trying to close, somebody is raising up the hand. Can you quickly talk? Z word. Unmute yourself. C-word, can you unmute yourself and talk? All right. I think she's having a problem unmuting herself. I want to appreciate every one of us for finding time to attend. Next month will be another one for another interesting topic. Let's gear up, and you should also try it. If you are not a member of SSPN, we know that there are many people who are here who are not members yet. Please take up membership, and you can try to contact us from wherever you have received this information. Unfortunately, I'm not sure I'm able to type in my number again. So have a beautiful evening and a good night to every one of us. Thank you.
Good
Good
night.
night.
Sir. Well
Good
done,
night,
sir.
Prof.
Good night,
Thank
everybody.
you.
Good night. And good
Our
night.
brothers in the house, Professor Leta Soyanwu, Professor Akinpedu.
Nice to
Thank
hear
you
your
for joining
voice.
us, ma.
Yes, so
Well done, ma.